Thanks, JP. Thanks, Manos and Manos, for inviting me to this amazing meeting and amazing city, and we're really happy to be here. So my charge is to talk about our long-term experience with a hybrid polyethylene glenoid component. Oh, I got to go here. These are my disclosures, and they are relevant to this discussion, as is obvious. So historically, we've had good to excellent results in patients with osteoarthritis and functioning rotator cuffs doing an anatomic shoulder arthroplasty. However, glenoid loosening has long been considered as a cause of long-term complications. The approach of the glenoid component replacement in anatomic shoulders must consider patient-specific anatomy, preservation of bone stock, joint line restoration, and in this case, durability of fixation, and then conceptually, the possibility of convertible implants in the future. Anatomic total shoulder is a well-established procedure in providing pain relief and improved function in patients with this kind of glenohumeral osteoarthritis. Aseptic glenoid component loosening remains one of the leading causes of revision in mid to long-term follow-up. The occurrence has been reported in some literature as up to 1.2% per year, with radiographic loosening in some studies being up to 34%. Given the impact of aseptic glenoid loosening, the long-term survivability of cemented all polyethylene components has been questioned. Modern hybrid glenoid components have been designed, and again, this is my disclosure. We've come a long way since the original near designs. Keeled all polyethylene, no mismatch radius of curvature, limited sizes, then a cemented metal-backed implant, then a 600% implant for perception of cuff tear arthropathy. They've had much higher rates, even in their early stages at 5 and 10 years. So we had to find another solution. We've also come a long way in terms of our understanding of osteoarthritis and the pathophysiology, better understanding of the disease deformity, the pathologic anatomy. We've also over the years developed better biomaterials. We now certainly have better planning tools and guides. We have better techniques as well, understanding, and now, hopefully, as we'll discuss, better designs. My own personal odyssey for anatomic glenoid replacement started way back when. I was only a teenager then. In 1991, we developed this system. It was an keeled all-poly system. That we had a metal tray system similar to the one that Charlie had described, but this was not fixed with cement. We had a metal-backed cemented system. And all of these gave if you had the same or similar results in terms of glenoid failure. That odyssey continued over the years where we tried to create an anatomic replacement that would attempt to give us better and more durable glenoid component fixation and possibly convertibility, not to disagree with my friend Giuseppe. That began with the comprehensive system in 2006. We had an all-poly system with a super peg. That was not used very often, but we did develop this hybrid porous metal-backed implant at that point, and that's the subject of really what we'll talk about today. Since then, it's been improved. We've developed a smaller peg so that we don't have to take out as much bone, and now we're even working into a convertible system. So what is a hybrid glenoid component? It's a component which is consisting of a highly porous central peg, metal central peg or cage, attached to the cemented polyethylene glenoid. And our system was originally a Regenerex titanium, but with porous plasma spray for fixation, and cement to give you initial stability, with a biologic fixation giving us long-term survival. Sorry? Okay. Recently, that system has been evolved with a smaller peg, as I described before, which gives us the ability to remove less central core bone with immediate fixation and still remains a revisable implant, as we'll talk about. The system that I'm talking about here has multiple glenoid face sizes, and they're all achievable through the same fixation, so that if you intraoperatively, if you find a problem, you can upsize or downsize the glenoid component. So technique, I'm not going to belabor this, but obviously you need great exposure. This is probably the most important part of the operation. Sizing can be done with these instruments which size your glenoid and they'll allow you to place the guide wire where you want it. Clearly, as Giuseppe has shown us, I think in our hands now, we use our systems, our planning systems in every case. Glenoid sizing, as I said, can be done with the implant or with preoperative measurements and preoperative guides if the patient, if it's necessary. The center peg, we then use our central reamer, and if we're going to do eccentric reaming, having that guide in the right place is very, very helpful. The central core reamer is then again over the same central core peg or pin, and then we create our anti-rotation pegs for the peripheral pegs that will be cemented in the final version. There's the dummy in place. We want to see that it's a see-through dummy so we know we're sitting exactly on the surface of the glenoid, and then it's cemented with the 3 peripheral pegs for immediate fixation as we get biointegration from our central peg. Now, recently, as we've come to recognize more importantly the different deformities that are going to occur and how we have to deal with them, we've created an augmented half wedge all poly system with the same hybrid peg, and we use that system, as you can see here, in the mid-range group of when we have to augment the glenoid from 11 to 24 degrees of retroversion with less than 60 or 70% of instability. And this wedge has given us another weapon in dealing with these severe deformities. The half wedge in this system, and again, there are different types of systems, gives us approximately a 10-degree correction, and it also can be used with a modicum of eccentric reaming to create even a better, if you will, better correction of the deformity. This particular system does have a very unique instrument which allows us to ream or surface the posterior wear from the front. It's based on a ball and hex feature, which really allows you to ream the posterior aspect of the glenoid if that's where the deformity is, without really, it gives you just better exposure, as we can see here, and I'm not going to belabor that. Here's some diagrams of the system where you can just figure out how much of an augment you need to use and go through the same process I just showed you. Not important, but here is where the rubber meets the road. Here's where we talk about, is this worthwhile or not? And we do believe there's a certain, we just presented our 10-year results, as you'll see at the Academy, but looking at our registry over 8 years, we had 1.1% revision rate in 1,200, almost 1,200 cases, and the majority of these were for soft tissue failure, not for glenoid loosening, the most majority. Early bone ingrowth, we've seen it. We've seen it in the revisions we've had to do for instability, rotator cuff failure. The first one up on the right, just so you know I'm not being prejudiced, is a case from John Sperling at the Mayo Clinic. We've had the same thing at 4 months. You can see the bone integration on that implant, and both of these implants had to be removed for instability. This system is revisable, not convertible, it's revisable. We have the system to remove with a coring peg that central implant or the bony implant, the metal implant, and it's the exact same size, and this occurred through serendipity with the system that we use for the central peg or the boss for our reverse shoulder guide. So if necessary, it can be more easily or revisable. I'll use that word better. So let's talk about the results. Originally, way back in 2018, seems like a long time now, we're in the COVID era, a 5-year follow-up by Quinn Throckmorton and his group in Tennessee, 45 patients at 5 years. They had minimal loose lines, and they were all lucent lines. They were all at the base, if you will, at the glenoid faceplate, not around the implant. They've only had one revision in that group for component loosening. A second study, again including Quinn Throckmorton and John Sperling, and Tom DeQuinn from Buffalo, they had 1,500 patients with the same implant with a 99% survival at 7 years. We recently reported at the Academy our 65 patients with more than 10-year follow-up. They all had very significant improvement in all patient-rated outcomes, ASES, STS, and range of motion. We had, out of the 65 patients, we had 1 loose implant, and that was secondary to infection, and 2 others that had to be revised, as I said before, for soft tissue complications. In a very large series now that was just reported and then presented at the Academy and just came out in JSES, the same group, Sperling and Tom and Quinn Throckmorton, presented 713 patients at an average of 4.3 years, but the longest being in the 9 and 10-year range. They had statistically significant improvements in all shoulder outcome measures and range of motion. They did identify glenoid lines in 57 patients, with only 1 had a radiographic evidence of a loose glenoid component. There were 54 complications, but only 4 related to any glenoid component loosening. And there, if you can see from their study, that at 5 years, they had 96.7% survival. And their conclusions were that these favorable clinical findings support the theoretical advantages of a hybrid glenoid fixation system. Now, of course, a larger, more comparative investigations with long-term follow-up are obviously needed to continue to validate these results. So in conclusion, hybrid glenoid component fixation with a central peg titanium demonstrated statistically significant and clinically meaningful improvements in all measures of a result. Though aseptic glenoid loosening remains a concern in these groups of studies, medium to longer range studies in this hybrid glenoid type implant, the incidence of lucency and loosening is much less than previously reported, and these favorable clinical findings appear to support the theoretical advantages of a hybrid glenoid component fixation as we move forward. Thank you very, very much.